I see this transition of menopause is so much more than clinical, even though it's a clinical diagnosis. It's this beautiful way in where we get to say, how do I want to restructure the rest of my life?
Where is the place to start?
So it could be as simple as, let me try and restructure my workout into transitioning out of so much cardiovascular exercise and beefing up my weight training so I can preserve my muscle, my bone. Or my diet. How am I going to improve the protein intake, the quality of protein too? What am I going to do in my authenticity, advocacy for myself that can help? And that's where I think we'll start to see the shift in how women prepare for it.
What's one message you would want every woman in her 30s, 40s, and 50s to hear about her health and her future?
All these pages I had written was really this love letter to women that I'd seen in my practice, to myself going through it. I really encourage.
Dr. Jessica Shefford, welcome back.
Yes, hi, it's so good to be here again.
You know what? Your podcast literally was ranked in that year in our top 3 most listened to.
Let's try and do it again.
Well, exactly. That's why we're going to repeat this.
Yeah.
Because I think that conversation was so full. But I really want to try to narrow this conversation down a little bit to kind of perimenopause, menopause. That said, I really do want to talk about what do women in the 30s need to do to prepare for this transition. This is going to be just a big old deep dive right in your wheelhouse.
I'm ready to dive in.
So what inspired you, because you're an OBGYN, you deal with women across the entire lifespan.
Yeah.
What inspired you to just really go deep on kind of perimenopause and menopause specifically?
Probably about 12 years into my practice, I realized that there was this gap. And the gap was these women coming in their latter 30s, 40s, early 50s with complaints, but they were so subtle. It was the subtlety of, I don't feel myself, or something's off, but I can't really put my finger on it. And as clinicians, we are trained to see the worst. We got you if you dying. If your head's blown off or, if your heart stops.
Little wiggles, no big deal.
Yeah. And so we are trained to look for, pathology. And so when someone really is in a physiologic flux, and something's happening, but it's not quite showing up on a lab, or we can't diagnose it as a disease, I think often we're like, you're okay. But what I do know is that when you start to look at the biology and the chemistry of what happens during perimenopause and menopause, you do know that there's something going on with hormones, but we're really not equating it to the experience of it. And so that's when I really had to take a step back and saying, there's something going on. And the funny thing is, it wasn't my MD community who I was like, okay, we've got this figured out and let's try and, take a deep dive. It was more my PhD colleagues who they were brilliant in the physiology of it and saying, these are really some profound changes that are going on, but then connecting it to the clinical space. And that's when I really was like, you know what? I'm going to focus on women who are in this phase and feeling how to optimize them a lot through lifestyle because I have an exercise physiology background. But I was like, there's also a lot in nutritional framework. There's a lot in movement and exercise that I felt most people don't have a good handle on. So I was like, this is where we need to do that.
Yeah, I think your clinical expertise is obviously super helpful in being able to kind of rule things out and help narrow the focus for a patient. What do you feel like are some of the symptoms that just keep coming up, or is it widely variable?
It is so broad. Everyone walks in with this different template. I say it's like the Cheesecake Factory menu. It's never ending.
Yeah, it's I'm 38 on pages.
Yeah, you're like, what? Why would I choose this, and why is this on this page? And so they come in with these varied symptoms of different intensity, frequency, severities. And so I think that's another reason why it's very hard to say. It's not number-based, right? It's not hypertension. It's not diabetes based on a number. It's very experiential and subjective. And that time it's very hard for someone who is science-based and black and white and this is the number and this is right, this is wrong, to saying, I hear you. Let's try and work with that.
Oh, yeah, there's this 38-page menu of symptoms, right? I think there's 175 at this point, right? But a lot of women, you said that women come in and they're like, I feel off. They don't have the language. And that's really what I've seen in the last couple of years is this kind of revolution in that, we're starting to kind of have a language. As you were writing Generation M and thinking about how do we help women develop a better understanding of what's happening with their body, where is the place to start for a woman who is starting to experience these symptoms, can't quite put a language to it? I think women often they're finally in so much pain that they seek help. how soon, does a woman need to start getting some help so she can stay ahead of it? Because I think, if they're like, oh, I'm just used to having these symptoms, or, these symptoms are different, but I don't really know what's going on. Like, how do you help a woman have a framework for, okay, it's get help so you can stay ahead of it?
And that was a lot that went into Generation M, was the fluidity of how you approach this topic. Because one, it is very stigmatized. A lot of women put menopause in this bucket of old. So then they're like, I don't want to talk about it because I'm not old. And we need to change that narrative of this is a transformation or a transition that's going to occur biologically. Like, you can't stop it. You can't avoid it. But what we can do is educate. I call it like a rebranding, is this kind of education in the earlier phases. Just like when we started, you're like, let's really look at how we can prepare better, is starting at a younger age. Because truly, when you look at the fluctuations of the hormones, they really do start in the latter 30s into the 40s, but we're not really discussing it to maybe latter 40s into 50s when they're really symptomatic.
Exactly.
So if we kind of give this, I say this all the time, if it were a screenplay, we have given it this horrific horror story of a movie right now where they're like, do not go down the street, and you're like yelling at the TV, like, don't go down the street, it's crazy down there.
Yeah.
Versus I'm like, I want it to be a comedic love story where there's just an authenticity
not a
to
flick.
it.
Yeah.
Right.
Don't go to the basement. God.
Yes.
Yeah.
Like, women should embrace these changes that are coming, not have it this like demonized thing that's coming with yelling and screaming and like running away from it. But as these things start to happen, what am I going to do in my authenticity, advocacy for myself that can help? And that's where I think we'll start to see the shift in how women prepare for it. And that's what I named it actually in the book. I was like, you have your pregame, you have your main event, and then you have your your kind of like after party.
Yeah.
And so that's how I kind of positioned perimenopause, menopause, and postmenopause. So it takes off the edge.
Yeah, I love that.
Yeah.
I love this idea. Of course, I like the sports analogy.
Right.
Can identify with a pregame. So pregame, let's say you're in your early 30s. Mm-hmm. The biggest group of women on our platform kind of is in that 30 bucket. So there's a lot of women who listen to this who are like, I know this is coming. As you pointed out, it's going to happen. What can women in their 30s do to protect themselves, if that's even possible, right? Like I have to believe that the healthier you are, the more great food you put in your body, the better sleep architecture, like the more aligned circadian rhythms, all of that is going to mitigate some of these, I would imagine, help soften the transition. Is that true?
It is very true. And I think that's where we kind of missed it in the beginning, in the messaging. We were doing the messaging when they were already in the disease process or, past that menopausal and that estrogen decline. So it was almost like we were playing catch up.
Yeah.
So now you already have sarcopenia and your muscle mass is lost, but go ahead and do some things that's going to increase that. Or you're already becoming insulin resistant, so now we're going to focus on things. So the goal really is exactly what you said, and I think we are starting to see that, although I do have to remember sometimes I am in a very kind of narrow path.
We're in an echo chamber.
Yeah, we're in an echo chamber.
We just hear each other over and over again.
And so many women actually don't know.
No, they do not.
That it could be as simple as, let me try and restructure my workout into transitioning out of so much cardiovascular exercise and beefing up my, my weight training so I can preserve my muscle, my bone, or my diet. How am I going to improve the protein intake, the quality of protein too? Because even now when I talk to my women in their 40s and 50s and I'm really trying to emphasize that protein intake, it's not easy. To be like, okay, I want you at 1 to 1.5, grams per kg, and then we like figure it out, and they're like, how much?
You're just off the reservation.
Exactly. So imagine that transition can be over the course of 5 to 10 years, where we're getting you up to speed. And lifestyle change is probably one of the hardest things that anyone can do when it comes to like personal life, your relationships, your health. So I would never expect anyone to do it overnight.
Right. Especially in your 30s, you typically have younger children. Potentially, or they're kind of in that, I feel like it took me until my kids were like 8 or 9 to kind of get out of that
to
fog,
breathe. You're just like, hi, I have kids.
Here I am. I am a human again.
Yeah.
So I think there's a lot of, we need to give some grace there. But I think, there are some things that we can kind of do in parallel, to kind of prepare. So we can't prevent. So this isn't a prevention thing, right? But it's easing the transition. So when we think about women in the 30s, so upping the protein is a kind of a simple thing to do. And you would say as much as, what would be your recommendation for a woman?
So when you look at like your weight, say, and I'm going to use, arbitrary numbers, if you're 130, usually it ends up being close to half of your weight in what you would want in your protein intake, which again, if you look at what you're taking in protein, it actually is very difficult to get to that number. Like even for myself, I wouldn't say that I'm at the ideal protein intake daily. And so I still work at it. But the goal is not for you to say, if I'm not here, one, I'm failing. But two is that I know what the expectation or what the goalpost is, and I'm going to work towards that. And then it's always there in the framework, and then stop working on this whole failure. You know, did you get there? Did you not? You're still on the journey. This is lifelong work. This is not like I stop at 45 and then I don't have to do anything again.
It's a new way of thinking about your life. Yeah. And then resistance training.
Yes.
22% of American women lift weights.
It should be higher.
I know. Talk about why does one have to resistance train if you're a woman? Why is that important? And then talk some specifics about what women should be striving towards.
So the body, I always say it's this phenomenal machine that we are in charge of. And that machine runs on really delicate kind of systems. And one of those systems is going to be like your musculoskeletal, which includes like your muscles and your joints and your bones. If we were to look ahead at your 80-year-old, 90-year-old self, what do we usually see? We see women who are frail, have increased risk of falls, breaking a hip, et cetera, and then they have decreased quality of life. So women typically live longer, but they live more years in poorer health. And that has a lot to do with the estrogen decline. And so when we think of why it's so important to utilize resistance training as a form to help the body, this machine, is because they talk to each other. So the muscle is really good for strength and power, and your bone is for stability. And bone, I think people ignore because it's hard, but it's a living organ. And so we have to use resistance training as a way to tell the cells in the bone to being like, I need more bone. And that comes with the actual impact that you do with resistance training that actually triggers the bone to tell it, right, the machine, we need more. We need more strength. We need more of those cells that are building the bone. Same thing that goes with the muscle. And so if we're not stimulating this kind of complex of the bone and the muscle, then that's when it starts to decline for multiple reasons. I think, with aging alone, you start to see that decline. But with estrogen, now it's kind of compounded. And so when women start to go through their 40s and their 50s, estrogen is declining. It's also impacting the strength of the bone and the ability to be strong, but also the muscle as well, and losing that muscle mass.
You do lots of different types of movement. We talked a lot about the resistance training, so would love to get your thoughts on kind of polarized training, because a lot of women have been doing the cardio and do love it and get mental health benefits from it, and then they're kind of like, oh my God, I need to stop doing that, I need to lift.
Right.
We don't want to go...
No, on all the other way on the scale.
Exactly,
I think right now, when I even hear the messaging, I do think it is a little, it's not that it's overkill, but because it's so important is why we keep emphasizing it until it becomes...
And when we're short on time.
Correct.
The taxonomy, when you're in this stage of life, you got to prioritize like heavy weightlifting.
Exactly.
Like that is like big.
And so it's, how do I get this thing that I really do enjoy? Because you want to take the enjoyment out of what they're doing. Is I even do that. I say, okay, on certain days, so if it's 4 days that I'm working out, 2 of them I will put in 20 minutes of cardio while still getting in maybe another 20 of weight training within that. Whereas some days it may be straight weight training. And so also listen to the body. I think there are days that I'm like, I really don't want to do any cardio. And some days where I'm like, I really feel like I'm going to do cardio today. So being self-aware and listening to what your body's asking for too. Like, don't go down the weight training thing where you're just like plaguing yourself.
Right.
Like, work into it. And on the days where you're just like, I don't want to do it today. Great. Get on the bike. Get on the treadmill.
I program with that like in mind. Like I'm like, all right, over the course of the 7 days, I'm going to do a sprint interval training. I'm going to do a zone 2, and I'm going to lift a few times.
Right.
And I just kind of, I wake up, what do I feel like doing today? So I know what I've got the program, but I go based on how I feel. And I think like as women, we don't do that as much. Like, we're not as intuitive with our training and frankly our eating too. And, I think that can be a really empowering way to think about it, because we're working with kind of our biology kind of tells us what we need in some ways. If we're like in tune with it, we can work with it. And you don't
get a medal for, because out of the 4 days you did all weight training and you deprived yourself. So find joy. It's finding the joy in what you're doing, but also, keeping a routine. Routine is very helpful. Your body loves routine, but also sometimes just like go off the path a bit and do what your body's asking.
Bottom line though, women need to work their heart.
Yes.
Like you need to get out of breath a couple times a week. I feel really strongly about
Absolutely.
that. Especially
I do too.
Where
My new thing is rowing. I really love rowing.
Oh, nice. Oh, interesting.
Yeah. I used to be like all running, and then I kind of went to cycling a bit. Then I do rowing. So I kind of like mix it up.
Oh, nice. I mean,
yeah.
That's
I think, the brain actually really thrives on change and not doing something
new
so
stimulus
monotonous.
is like so powerful.
That neuroplasticity is like, change it up for me.
Yeah.
And your body actually will respond better when you change it up sometimes too.
Yeah.
So a lot of people, that's why in weight management, when they're losing weight, they hit a plateau.
Yeah.
Because they have to do something different because the body can accommodate and remember anything.
Yeah. For sure. Menopause is often referred to as a metabolic disease.
Yeah.
Right? So how does resistance training kind of offset that?
Alluding to that analogy of the beautiful machine that our bodies are, really a pivotal part of it is obviously your mitochondrial health, your metabolic health, but that insulin and glucose machine, right?
Yeah.
And our body fuels off of glucose, which is very important. So it's not that glucose is bad. I want to, kind of debunk that myth as that glucose is bad. It's how you're utilizing that glucose really is the important part. So as we're starting to get older, again, because of aging, insulin and metabolic systems are starting to kind of being like, not doing as well.
Yeah.
It's aging. But when we are not utilizing that glucose as fuel as best as we can, and the largest organ system that utilizes glucose is your muscles. So if you're not building your muscle, it's not intaking that glucose, and then the machine is not running efficiently, then the glucose sits around, and then that's when our metabolic portion of our health starts to decline as well. And that's why we see our fat shifting. It's kind of like going to a place where we never invited it. You're like, why are you in my midsection? Because I didn't want you here. And so that's what you start to see.
So resistance training can kind of help prevent the body fat around the midsection. That doesn't have to happen.
It doesn't. And I think you can slow it. Does the body want to do it? And is it going to start to do those mechanisms? Absolutely. Do we have the ability to thwart it and kind of like hijack it in a way?
Yeah.
We absolutely do. And those are the ways that we can do that with
so
resistance
training is just, how many times per week do you recommend women resistance train?
I always say start slow. And work your way up to it.
Yeah.
Just like anything. Just like that January phenomenon where everyone's in the gym and then by February we're like, where'd everyone go?
I know.
The same thing of the mechanisms of getting to a place where it's sustainable.
Yeah.
Duration,
so something
sustainable.
you can do weekly.
So I would say work up to ideally 4 times a week.
Yeah.
Right? And the resistance training can come in a variety of different forms. So a lot of people are still very scared of weight training, like heavy weight training. And so if you can do that maybe 3 times of the 4 times or 2 times of the 4 times, and then integrate other forms of resistance training, which would be like your Pilates, yoga, a little bit of like body weight to do resistance training, you can also implement that as well.
The message, though, I think you'd agree, is people need to move heavy weights.
Heavy
they need
weight
to work
is going
to
to
that.
get it. Yeah.
It's just like that's the most efficient way to build muscle and to improve the quality of
Let me tell you that
tissue.
this is like, it's not that it's new information for me. It's very new for a lot of people. But even up to, I would say maybe 5 years ago, I've always really been lifting weights, but I wasn't going as heavy as I am now because I wasn't truly understanding the beauty of heavier weights. I had a patient yesterday talk about the same thing, resistance training, but I always go a step further. I'm like, how much weight? Because everyone will be like, if they are weight training, they'll say I'm weight training. And she's like, about 10 pounds. I go, we're going to get you to doing 25, 30 pounds. And her eyes were big, but then I explained to her and she was like, great, let's start working up. You just have to.
I think we're obviously in very privileged position in that we can afford. We have resources. If we want a coach, we can get a coach.
Yeah.
And a lot of folks don't have that.
Right.
There are a ton of resources online. A lot of, I recommend folks follow you online, Dr. Jessica Shepard, for inspiration. But there's a lot of apps that are really good.
There are.
At helping people that are inexpensive.
And it's being curious, I think, it's one of my favorite things is curiosity breeds growth.
Yeah.
And so sometimes that's our homework. And I tell my patients, I can help you as much as I can here in the exam room or the OR. But when you leave here, what is it that you're going to take that you're going to be your best cheerleader and start to do some things, turn some new leaves, do some new exercises? You have to do that work.
Yeah. I think that's like the kind of the realization or that no one's going to put your running shoes on for you. No one's going to be in the gym. And
my sister always says this. It sounds really depressing, but it's actually really true, is that no one's coming to save you.
I know.
No one's coming to save you.
I know.
And so you have to find the ways that are going to save yourself.
And at the end of the day, no one is going to care about your health more than you
More
are.
than you.
You know, like, it's just like you have to like just
lock in.
You have to lock in and just be like, all right, like, these are just the things. This is part of the human experience.
It's part of the journey, part of the experience. And that's where we get to drive that experience, is really being in charge of ourselves.
For sure. And I think that's also an act of service, right?
Isn't it? That's such a great way to put that.
Like, whenever I feel my motivation wane, that's what I play that back in my head. This is an act of service for my kids.
Yeah.
You know, so 20 years down from now, they're not having to, like, you know, wheel me up right.
Because there's actually like a lot of guilt that comes with that when you're just like, later you're just like, oh my gosh, this is something that now someone else has to carry that burden.
That was preventable.
Yeah.
You know, it's like, just take care of the things that you know that you can control.
Right.
And, you know, getting in the weight room is the first step. Getting the protein is,
it's not scary. I really encourage, especially people who are listening to this episode, but anyone I encounter is, a lot of times it's out of fear. But
of course.
Once you kind of push through that, or find someone who's going to, like you said, encourage you or kind of get you curious, do it. Because it's so much better when you push through that fear to do the thing.
Yeah. Don't be shy. You know, everyone has got their own thing they're focused on. Like, they're not looking at you. Don't worry. Like, everyone was there at one point.
Absolutely.
They were a beginner, you know? So it's just taking that first step. But I mean, I think we really need to get, you know, women in this country lifting weights.
We do.
You know?
And just movement. You know, I always like to, I think exercise sometimes is scary. So sometimes I tell my patients, it's really movement. Like, park your car further and walk. I don't know, take the stairs and celebrate. Like, start somewhere and building into it.
You talk about this, you know, exercise snacks, I think is a great way, you know, just building movement in throughout the day, which can be even more effective than going to the gym for like an hour block. You know, I think a lot of folks are sedentary for really long periods of time, which can exacerbate a lot of the symptoms associated with perimenopause and menopause. Like, just getting out and thinking about, all right, go over the course of the day, how many little snacks can I build in, you know, whether
like,
it's sit-ups or body weights.
And that's why, you know, when we think of, you know, decades or even centuries ago, we were never really designed to sit and kind of be as sedentary as we are now. We were really more of creatures that were movement. We were movement creatures, and that's how we survived.
Yeah.
And the body is literally set up to function in that way. So now it's actually, we're trying to do like work behind the scenes to get us back to that place. But that's really what the human body is. It was really meant to be moving.
Yeah, totally. And the modern world is just not set up
we're
for
not
that.
moving.
You know, we have elevators and we, you know, like, there's so many conveniences.
I mean, they are convenient.
They're amazing, especially when there's 7 floors.
Yeah.
You know, which is it's a modern thing,
there
right?
weren't 7 floors back in the 1800s.
Exactly, right. But yeah, I mean, I think it's just, I think you give us like, I think our listeners a lot of ways to rebrand. Rebrand. I love that, you know, and I think sometimes it's like rebranding at the level of your life.
Right.
You know,
it's all stages and phases. And, you know, you may be in a phase where you're really strong and you're able to go to the gym 4 times a week. And then you may hit like a little rut where something happens to you. Yeah. Maybe you get injured. Maybe it's your personal life. And once you keep it as part of like your mantra, it really will weave itself in naturally. But consistency is never a straight line.
Yeah.
But you want those fluctuations to be as minimal as possible. But there are going to be fluctuations. And that's when you were saying before, give yourself the grace, but always know that you're working back towards that consistency.
I love that. What biomarkers should women be paying attention to as it relates to metabolic dysfunction? Just, you know, kind of staying on this theme of, all right, resistant training protein kind of is a path to kind of get us in a better place. You know, what biomarkers can women look to understand
I
where
would
they sit?
say, you know, we have this kind of controversy of perimenopause, which is usually through your latter 30s into 40s, of do we draw hormone labs or not? I want to start out with that one because that is a very common question.
Yeah.
And the answer really can be looked at from different perspectives. So, for example, from a clinician, from a doctor's standpoint, when a patient comes in and says, I'm perimenopausal or I'm still having my cycle, I need you to draw my hormone labs.
Define what would be perimenopausal.
Absolutely.
Real quick.
Perimenopause is that time frame which can last anywhere from 3 years to 10 years prior to menopause. Menopause is such a clinical term. All it means is a woman has gone 12 months without a cycle consecutively. Like she has not had a bleed, spotting, nothing for 12 months.
Okay.
And it's like right at that 12th month, we can be like, you are now officially in menopause. And we throw a party, whatever, confetti. But that time frame before that can be from 39, 43, where you start to have fluctuations in your hormones as it's preparing for menopause. This is where you start to see those fluctuations and you get those symptoms subtly here and there, hot flash, night sweat. But usually women will start to complain of changes in their cycles.
Yeah. So
heavier
bleed.
Yeah.
Irregular,
lighter,
color.
miss a month, change in color, like all these different nuances that they're like, what is going on? And that's the fluctuation.
Okay, so that's a signal that
yes,
hey, you might be entering into perimenopause. Okay.
As a woman comes in and they're asking about like, you know, my overall health, or maybe I want some labs, a clinician will stand and say, the labs are not necessarily going to help me because I know you have a cycle. So I know you're not menopausal. I know that your ovaries are still giving off estrogen, progesterone, and testosterone. So it's not always helpful for me to look at and say, it's there or it's not there, it's high or it's low, because I know it's still there and it's fluctuating. So it's hard to calculate. Now, is there a way to maybe give a woman reassurance and a baseline? Absolutely. So I'm never opposed to being like, I will not do it.
Yeah.
But I love to give fundamental information behind it on why it may not be the best tool. Now, when I say those labs, I'm usually talking about estradiol, progesterone, testosterone, and maybe follicle stimulating hormone, which is FSH. Outside of that, that's a reproductive hormone panel. Outside of that that's where we start to look at, we should be looking at and asking for your thyroid panel, a full panel. So not just TSH and T4, T3, but the full panel to see what's going on in your thyroid on front office and back office, as I like to call it. Like, what is the full, complete profile? Another one, hemoglobin A1C. Hemoglobin A1C is one of those, we talked about it, metabolic health markers that really is telling us most people are going to start to become insulin resistant. We're not quite sure how quickly. Do you have family history? What does your previous health look like? So it is a great marker for us to be like, hey, we got to shore some things up because you're heading towards diabetes or prediabetes.
And you can be eating really well and exercising and still experience
a shift.
And this is because of just the hormone shift.
Because of the hormones.
Yeah.
And so that's why estrogen is such a key player in all of the different functions of the body, including metabolic health. So that's another thing that we used to do is wait till someone was like, oh my gosh, like my sugar on, just a normal panel was really high and they've been diabetic for who knows how long.
Yeah.
So the hemoglobin A1C really gives us like this prediction of what's going on. The other thing that I would say is your vitamin D levels. We see a lot of drops in vitamin D and B12. So those are two key vitamins that I always say are very important to draw. A lipid panel. We do see, usually in the later perimenopausal and the early menopause phase, of a shift in the lipid panel, specifically in your total cholesterol and then your LDL, which is not your low density lipoproteins.
Yep.
So that, again, is something that could start because of two things, aging and feature of menopause, where you start to see these shifts. Again, we don't want you to be hypercholesterolemic. We want you to catch you before you are. So that's a great time to do that as well. I would say that's the most basic. There's a lot of other cardiometabolic kind of markers that I draw, and that's usually kind of like a little bit of an extension, maybe if I have maybe a perceived notion, but then it usually comes with a lot of privilege as well because those labs are really expensive. The one that I gave is really nice and basic. Anyone could ask for those.
Amazing. Do primary care physicians actually, if someone goes in and asks for them, can you get them and can insurance cover them? Those?
Man, this is a whole nother session of this this podcast, is because this is why healthcare in America to me is not great.
Yeah.
Is because insurance should be covering these things, right? Because what are we talking about? Prevention. And I feel that there are a lot of instances in healthcare in general that is not covered because we're waiting for the disease to appear. And so it does depend on insurance coverage. It does depend on what are the recommendations noted by a body that says at this age we'll start to do these things. And so it's not always covered. I always say I would advocate for a patient sometimes to be curious and say, what is actually the cost if I didn't use my insurance?
Right.
And sometimes it's actually less than you might think. But even if you just had a screenshot or a snapshot of what you are in that time, think about how much you could do with more knowledge. Yeah. And so I always advocate for patients to ask how much it is if it's not covered. And then for clinicians to, even if you don't think that it might be the best tool for that patient, reassurance and education for a patient is one of the best things that you can do for them. And sometimes it's okay to draw a lab. Do you need to draw it every 3 months? Absolutely not. We don't need to go overboard. Yeah. But sometimes it's okay to do that for a patient.
What would be your kind of toolkit for women in perimenopause who are experiencing, irregular cycles, heavy bleeding, like just some of like the very typical kind of features of perimenopause that are totally annoying and like, just can really are debilitating in a lot of ways.
They're
What's your
debilitating
recommendation?
from like an emotional aspect or from quality of life.
Yeah.
So this is where that's a tricky time frame in where you can still get pregnant, but you're less likely to.
Yeah.
And so for a lot of women, I do say you have the opportunity to still continue on a form of birth control or not. And there are some medications that are non-hormonal and are not a form of birth control, rather, and also non-hormonal that do deal with heavy bleeding, that are not a form of birth control, and then also deal with just during the cycle portion of decreasing that bleeding. Then there are obviously your hormonal birth controls that you can still navigate through. And then there's really one non-hormonal form of birth control, which is the IUD. It's the copper IUD, which can help prevent pregnancy. It doesn't necessarily always help with the bleeding profile.
Yeah.
But the other aspect
and can
of
in
that,
fact increase
it can.
the bleed.
That is one of the things with the copper IUD, I would say.
Yeah.
But it's one of the ones where people are really like, I don't want to take birth control. Because then the other thing is you're
introducing.
We've had pregnancies.
Yeah.
So that's like a little feature I always make a nod to not forget that even though your cycles are irregular, that you can't get pregnant. You can.
Yep.
But looking at maybe non-hormonal forms of birth control, and there are medications that just deal with heavier cycles that you can take.
If for women who are concerned about birth control, what would be the taxonomy for those folks? And obviously very individual, but just at the highest level,
right? I would
for
say
Gen Pop.
Very individual advice, and again, not medical advice, because you really have to like narrow it down to where you are. I would say most women who I encounter in my practice who are in that time frame of perimenopause are really looking for convenience. And they're like, I have too much to do. I want something that's not going to interfere with my daily life. So the IUD usually kind of ranks in that top frame of something that they can put in and not have to worry about. Gives them really good protection from decreased bleeding, but also from endometrial carcinoma because it has that kind of protective progesterone effect.
The endometrial lining.
Yeah, to the endometrial lining. And it really allows someone to stay flexible in their life and not have to worry about something.
Yep.
The next thing that I would say is actually the Nuva ring, which is what you insert.
Okay.
Again, that is you wear it for 3 weeks, 1 week off, right? So then now we're looking at what do you have to do that's less occupying of your time, and you still get the best benefit from it.
And now that's a birth control.
It is. With both estrogen and
progesterone.
Yes.
Okay.
And so that's a combined, whereas the IUD is just progesterone.
Just progesterone, that's right.
Just progesterone. And then you have your birth control pills, which obviously a lot of people actually still just do it because it's so rote. It's like part of their muscle memory. They're like, this is fine. And the good thing about birth control pills, I would say, because that was our first version of birth control, we've had so many reiterations of it.
Right.
There are actually a lot of combinations that have really low levels of estrogen that you don't really necessarily get those shifts in moods.
Right.
And it's just giving you that baseline to kind of calm the bleeding down and then also prevent pregnancy.
Yep.
Yeah.
I think that's super helpful. Let's talk about estrogen, the vaginal creams.
Yeah.
When does a woman start that? Why would they want to?
Yes.
And, just give us the lay of the land
I
there.
always
Because I know that's really popular now.
Yeah,
a lot of
the
discourse.
vaginal estrogen cream, I feel is like a condiment. It's like ketchup. It's like everything can have ketchup on it. Pretty much everything. It's like there's not a lot of contraindications because when you bring up like estrogen, whether it's birth control or HRT, a lot of people get a little nervous, sweaty palms. And so when you think of the one that could cause maybe the least hesitation is vaginal estrogen because the absorption rate is much less than you see in systemic estrogen when you take a pill or a patch, et cetera.
It's super efficacious.
It is super efficacious.
Dealing with dryness and all sorts of,
because it's local.
Yep.
So it's at the site at which it's doing its best work, which is vaginal insertion, or even on the outside. It really helps with decreasing vaginal dryness, which is a really big part of this whole experience of perimenopause and menopause. The thing that I love about it is this is where I really like talking to my breast cancer patients. Because breast cancer survivors are usually the kind of like this hard line, you can't have hormones anymore. And there was a really pivotal study that was done at the end of 2023 that was looking at what is the recurrence rate in people who have had breast cancer in using vaginal estrogen. And there was no increased recurrence of breast cancer, which then makes it safe for breast cancer survivors to have some form of estrogen, especially when they're going through this really severe shift in their hormones. A lot of them have vaginal dryness.
Right.
That's why I really love the feature of the condiment of HRT, which is vaginal estrogen.
And even if you're not experiencing vaginal dryness yet, it's such a great
It
prevention.
is.
And also prevents, and also it's been shown to reduce the risk of certain cancers. Right?
Yeah, it actually can. And so I love that it replenishes the vaginal mucosa, right? So the vagina, if you think about your childbearing years, right? In your reproductive years, the vagina obviously has a lot of rich blood supply, which is why you're able to push a baby out your vagina and then it goes back. Funny, right? A lot of elasticity and flexibility. But that has a lot to do with the estrogen. Right. And so once you lose that, you lose the distensibility, the elasticity. So it actually is a great way to be preventative, but also for women who are suffering. I'm like, we do not have to live like this.
Yeah. And it's super easy to use. I met Kelly Casperson in November. And ever since then, I was like, okay, where do I get this vaginal estrogen cream?
Right. She loves talking about vaginal estrogen.
She sure does. I have been putting it on my skin.
Yes. You can use it for your skin because we have estrogen receptors.
I put it with my retinol.
All over our body.
I know. Exactly. We've got, estrogen receptors are everywhere. Okay, amazing. All right. So hormone replacement therapy, menopausal replacement therapy. I know it goes by a couple of different names. What is it, and when does it make sense for a woman to consider it?
Yes, I love the way you phrase that question because we have had so much kind of stigma against it can't be used. So we're like 20 years out from WHI study, which was a study done 20 years ago.
Explain that real quick for listeners who might not be aware of just that
very quick overview. Disaster of a study. Which the funny thing is, it was a great study in how it was proposed because it was actually looking at cardiovascular health.
Right.
And the implication of decreasing cardiovascular events, which is the number one killer of women, and what hormones does for that. What happened during that study is that there was a slight increase in breast cancer cases. Like any study should do, if there is something that is occurring that can be a detriment to the population of women in this case, then you stop the study so you can see why is this particular thing happening. What got out to the press was really the one who I feel kind of ruined the outcome of what the study was by just saying there's this huge study that's going on and estrogen causes breast cancer. And then they just let it
the headline
sit.
with I know.
And then everyone is running in the streets being like, oh my gosh, everyone who's on HRT, get off. You're going to get breast cancer. Everyone's getting breast cancer. Clinicians, I don't even think they were given the right information.
No.
Do you know that from the years of, so that would have been 2002 around to 2024, say, the amount of prescriptions that were dropped from that time, 84% of HRT prescriptions that were written had gone down by that much. So imagine the amount of women now who were on it or wanted to be on it or were considering it.
Were denied.
It just wasn't even a topic anymore. It was like, it goes out with the bathwater. And so from that study, there was kind of this misnomer that hormones are bad. But all the while, like true scientists do, which is why I love bench research, is they did their due diligence and going back and looking at it retrospectively and being like, what the happened? And when they looked at it, it actually wasn't the estrogen that increased breast cancer rates. It was the synthetic progestin that was used in the study that increased the breast cancer rates. So now you had everyone being like, oh my gosh, this was not even what happened. And also we didn't maximize the benefits of the WHI study was we had decrease in osteoporosis, dementia. When we look at colon cancer, rates were decreased. And so from all of that, it was just messy. And so now fast forward, we really have gotten to this point where we're like, we are so sure of what we are in HRT. We know the benefits. We know that estrogen does not cause or precipitate breast cancer. I like to rephrase that because there's never absolutes. And what we do know is that it is very beneficial, not only for symptom resolution, which is hot flashes, night sweats, all the things we talked about, but longevity. So now we know what you want to show up as the version of your 80 or 90-year-old self when we think of the three things that probably kill women: cardiovascular disease, osteoporosis, and then you fall and have a fracture, and then also dementia. Right? Those three things are actually significantly benefited and decreased when we put in estrogen replacement therapy or hormone replacement therapy, rather.
When we age, estrogen declines, so does our sleep quality. Low sleep quality, increased risk of neurodegenerative disease. That's why women have more risk, cardiovascular and Alzheimer's risk, right?
Alzheimer's,
I think the key is estrogen
diseases.
here, right?
Oh, it is. And that's why
it impacts sleep.
the book, The Menopause Brain,
Yeah.
by Dr. Lisa Mosconi, because we are seeing the research that estrogen decline, that significant time frame in between the 40s and the 50s, if I were to categorize it 45 to 55, estrogen declining is where we start to see increase in plaque formation, increase in inflammation, decrease rather in protection of the heart, which is why you have heart disease, and then you have atherosclerosis. So all of these things, it's just
Those
like
cleaning mechanisms start to...
the body is not able to do the machine. Going back to that beautiful machine, it can't function as well. And so you're going to have these little blips and things that are happening more often. And that's what's happening in the body, and then it shows up in our 80, 90-year-old self. Isn't it fascinating how the body works? That's why I love science and
I know.
the ability to look at how cells respond, how they act, how they tell the other thing to do.
I know.
You're in charge of this.
It's just this beautiful...
It is.
Orchestra of communication.
And that's what I've actually used that analogy of the orchestra. And then what happens during this time frame.
Every circadian physiologist uses the orchestra analogy.
Isn't it? It's just like this beautiful thing. You'd never want to go to an orchestra if there's like this flute and this like trombone that sound horrible. You'd be like, this sounds wonky. And that's what happens with the body when we're not creating the synergy and the homeostasis that it deserves.
Yeah, so we want to try to work with our body as much as humanly possible. And
and women actually didn't live as long as they used to.
Yeah.
Because of estrogen. So if you think of just ourselves as creatures, like way back in the caveman days.
Yeah.
Women, and even, in the 1800s, the lifespan of a woman was actually in like late 50s.
Right.
A lot had to do with decline in estrogen.
Right.
So now we've kind of progressed society-wise or, just like science-wise, we live longer.
Yeah.
But the ovaries are still...
Well, we can keep people alive with medications.
Yeah.
So
we keep people alive, but the ovaries are still like, I'm piecing out at 52, average age of menopause. Decline of estrogen is going, but we didn't ever fill that gap of estrogen going down. We're living till 80. And now this estrogen's like, I'm not even in the picture anymore. And your machine and your bodies and your organ is like, what are we doing?
Yeah.
And they're malfunctioning. They're dysfunctioning. And so that's really where we need to, what is going on in that gap? And why are we not educating women? And why is women's health not imperative when we think of research?
When should a woman start taking estrogen? Is it like... at the onset of perimenopause where you start to experience these irregular cycles, or is it, once you get to that 12-month mark where you have not had a period? And I think the second question, for women who are on hormonal birth control, who are not bleeding.
I love this,
What do they do?
I know. So I'll save the second question because it's very convoluted and individual, like all of this is.
Yeah, of course.
But we have changed how we treat women with hormone replacement therapy. So even myself, when I was training in residency, we did not treat women with hormone replacement therapy until we were like, you have to be confirmed menopausal.
Oh, interesting.
And that makes me sad because there are a lot of women who came to see me and they would come with the symptoms of, I'm having hot flashes, I don't feel great, something's off.
Sleep.
Periods are really weird, sleep is off, I feel depressed, I feel mood changes. And we were taught, have you had a period? When
give
was
them
your
an
last period?
SSRI and send them on their way.
Because we were like, well, we can't give, we didn't have the correlation or the knowledge behind estrogen and mood.
Yeah.
But the other part of that was we were like, you're not menopausal. So until you miss your cycle for 12 months, we can't really start HRT. But the beauty of that is now we know you're already starting that fluctuation. You're starting to have these symptoms. You deserve estrogen or hormone replacement therapy rather, even including testosterone, to give you that buffer back so that your fluctuations are not as severe and you're having these symptoms. It's almost, it's definitely the gas tank analogy.
Yeah.
You don't wait till, I have a few times there until it's completely
it's totally empty.
And you're like, oh my God, my car is not running. But ideally, when you get that little signal,
that warning light comes on the dashboard.
That's why the signal is there.
Yeah,
it's like you are close to empty. You should probably go to a gas station.
Your car just stops working.
Exactly. And so why would I wait till menopause, till the tank is empty as far as estrogen release, to give you back just a lovely low level of this hormone replacement that makes your fluctuations not as severe and makes you just feel better? How about that? How about we just make it as simple as you are having symptoms and I want your quality of life to be great.
Is it actually replacing estrogen? Can you clarify?
Yes, I love this. And that's why we do have this difference between menopausal hormone therapy, MHT, and HRT. Yeah. It's a little bit of a rebrand, in my opinion, and I think that is because HRT is very synonymous with WHI study and people get nervous.
Yep.
But really what we're doing is we are not replacing, because we're not replacing to the levels that you used to be maybe in your 20 or 30s.
Right.
What we are doing is allowing you to have this kind of ambient level of hormones that allows your organs to function to what they need to be. But we're not giving you like enough we want to get you as high as when you're ovulating and when you're releasing a follicle.
Right.
It really is more so for symptom resolution, but also for organ function.
Mm-hmm. So I've seen online a lot of women who might not have gotten on board yet with the lifestyle stuff.
Yeah.
And are kind of thinking, all right, MRT is going to be the be all end all for me.
Yeah.
Can you have a lot of success with MRT without also in parallel taking care of the lifestyle?
I really love this question because I'm a firm believer that lifestyle medicine is going to get you best bang for your buck.
Yeah.
In society, we do see that lifestyle is one of the hardest things to install in our own lives.
Of course.
And your body does, it's a chemical messenger. Hormone is a chemical messenger. It's telling something what to do. You will see a lot of benefit. I've seen a lot of women who maybe have lifestyle issues or obstacles or journeys or just quite frankly don't care.
Yeah.
And do feel better.
Yeah.
So you will get that outcome.
Yeah.
You'll have the decrease in the symptoms. But that's why I like to put it in kind of two categories. And we talked about this before of symptom resolution, what your body's going through at the time, and longevity. And so what we will start to see now that we're kind of, putting a lot more women on hormone replacement therapy is in a few years we'll be able to see forecasts. Like now women have been on it for 10 years. What are we seeing in this data that's showing decrease in osteoporosis and atherosclerosis, in inflammation? A really good way that I like to categorize what is happening in the body, because it's very hard to tell a patient, oh, your vessels are having more plaque in it. They're like, I don't see it, right? And so that's why disease is such a prominent thing, is because we don't see it. It just, when it happens to us is when we're like, oh, my vessels are clogged.
Right.
So the goal really is, how can we allow people to have kind of a visual to what's going on in their body? And that's why I like some of these newer tests that look at our glycans, which are actually a feature of inflammation. Because then it gives someone a picture of what's happening internally. And it actually is a bit more representative of the things that they can do, rather than me just looking at a number on a lab and being like, oh, your total cholesterol is up. They're like, okay, well, I don't see my vessel. Yeah. So I'm not sure what's going on. And my heart might be like pewtering out. But until maybe I have an arrhythmia or I fall over, that's usually people's wake-up call, right?
Yeah, that's wild. I mean, that's where like data, like from, for example, it's just like so beneficial, right? If your arteries really becoming clogged, like you would see that manifest in your resting heart rate very simply, right? Like you would see changes and they'd be pretty drastic, right? Which would be a nice call to action to, get some help. But so if we've got a scenario where a woman is on birth control in perimenopause, right? So
we're coming back to this question.
Yeah. So let's come back to it, because there's two separate discussions. You've got birth control, so you're not bleeding, and then so you don't even know if you're in menopause. Yeah. And let's say you're not experiencing any symptoms at all. Should you just go on HRT anyway? And then a woman who doesn't know they're in menopause, they're on birth control, but they're experiencing a lot of symptoms. If there's an absence of symptoms, are you just good to go?
Well, that's a great question. That's the individual's question. And this is how clinicians should really guide someone through that, because we still associate that whole transition with like symptoms. Yeah. But not everyone has these severe symptoms, or they may have it, but it's so subtle. They're like, it's not really bothering me. Yeah. And they may be on a form of birth control to help with, pregnancy prevention. Maybe their bleeding is significantly decreased, or they don't have any. So they're just kind of like, going through life, doing it well. Yeah. But they get to decide, do I want to do this now for the longevity reason? Okay. Because they're not having symptoms. Right. And they get to decide, do I want to come off my birth control, even though there's a really small risk of me becoming pregnant? I've had a few patients like this, or a lot of patients who come in, same question. I say, actually, you have more decisions, but it does make it a little bit more hard because you don't have a symptom, and you're like, should I stay on birth control? So I usually tell them, you could do a trial without your birth control, one, to see if you're still bleeding, because maybe you don't even know that. I mean, we could do labs, and the FSH would tell us if they're menopausal. But if they really wanted to be like, I don't know where I am, I could draw a lab, or I could say, let's stop your birth control and see. Because Birth control still does have hormones, so it could be actually suppressing some of the symptoms.
Right.
So if they came off, they may be like, oh my gosh, I am having hot flashes and night sweats, which is why some women stay on birth control and some doctors and practitioners
it corrects for that.
It still does. It's just at a different level and usually a different source of hormones. HRT usually,
such a great point.
It's going to be different types of estrogens. You have 3 types of estrogen, but you also have your synthetic forms and then your bioidentical forms.
Yeah.
So HRT is usually a lower level of estrogen, usually going to be more of an estradiol base, which is your E2, and then it's also going to be not all the time, but most of them are going to be bioidentical. Whereas birth control is going to be a synthetic. It's usually like ethanol estradiol.
Yep.
It's going to be your synthetic progestins, higher levels, and its goal is to suppress ovulation. So it's doing a different task, but you're kind of getting a twofer.
Yeah. Okay.
Because HRT is not birth control. You heard me say that here. Because you don't want to mix the two and being like, I'll stop my birth control, go on HRT, and I'll be protected from pregnancy. Yeah, and then we're like, oh, well, your belly is getting, let's get an ultrasound. And that's the pregnancy.
So if the egg isn't getting released, you're retaining the egg.
With birth control?
Yeah.
It really just, in the physiologic form, it suppresses enough of the normal cycle of what your body is doing.
Yeah.
And so it's not like it came up with one and suppressed it. It just never did it.
Yeah.
It was just like, oh, you suppressed me enough where I'm not going through the normal function.
Yep.
And I didn't even do it.
Yeah. How do you ask for this when you're at a very practical level? Like, what do I say to my OBGYN? Be like, all right, I really want to give this a go. Maybe from the standpoint of I mean, would you say at this point, like every OBGYN in America is like onto this stuff?
Absolutely not.
Okay.
I think
this is so depressing.
It is. And, I think there's 2 reasons. One, there was such a kind of like whack-a-mole when the WHI came out. So it was like, do not talk about it. We're not doing it. Abandon ship.
Yeah.
And then also,
not to mention insurance implications. Like, I mean, poor doctors, in a lot of ways are in between a rock and a hard place.
So it was kind of like, don't talk about it. There's a lot going on. It causes that was really the prevailing message. Is it caused breast cancer. So no insurance was going to be like, oh yeah, put them on HRT. So there's no coverage. People were like, I'm not doing this. There's fear. It was very fear-mongering. Right. So I would say now, coming out of that, people still are hesitant. Our data is there, but it's not as widespread as we would love it.
Yeah.
And so people now have to come out of what they know, their practice, go learn something new, go to courses, figure out what the new literature is. That takes time.
Yeah.
And myself and my colleagues work so hard that sometimes the time is not even there to now go back and learn this. So for me personally, I had to step outside of my practice to do the studies and the research that I did to become a menopause expert, but not everyone has that. We are taking care of very sick people. And so it's like not like the whole labor force is going to come out to learn about menopause. And then we're also not seeing it at the level of maybe organizations of saying, hey, we need to restructure our recommendations so that doctors will read those and change their practice. So there's so much that needs to go on. Medicine is definitely the career or the kind of society that we have to be sure of what we're doing. So we go slow. We're not like tech where we're like, let's go. And then if you make a mistake, you're like, okay, well, that was kind of great. Medicine, we're like, we can't make mistakes. And so it usually takes like a good 5 to 10 years before you start to see a huge shift. That's just what science is.
Yeah.
I think we will see it. I think we're on the right course.
For sure.
But it's not for tomorrow. Yeah. So that's why we just have to keep talking about it.
Yeah. Blah, 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 blah. Yeah. I know. I'm just so grateful for women like yourself and Dr. Mary Claire Haver and Kelly Casperson and Dr. Vonda Wright. It's just there's a group of you, who are just really at the tip of the spear in terms of like getting this message. Yeah.
There's a message and it needs to be said. And the other thing that I want to make a nod to is it's no one's fault. No one should be blamed for, there's a lot of things that happened, and instead of focusing on the blame and who did what, and there is a lot of out there, noise that we were wronged. Yes, there was something that occurred. My goal really is, and I think that this has a lot to do with my messaging, especially for women in Black and brown communities, is that a lot of times they are left out of what's going on.
100%.
They're left out of the messaging. They're
left out of the research, big time.
Left out of the research.
In just ways that are just
exactly.
Just
and so
shocking.
I need to focus. My focus really is on how do we make our lives better from here on.
Yeah.
And that's what we need to focus on, especially with hormones, because we are going to save women's lives with what we are able to give them now in the pregame and the main event.
Yeah.
And show up better as our 80, 90-year-old selves.
Yeah. And I think, as you were a woman in midlife, and you're just like
I'm like me,
an insanely inspiring role model. And I think like what you show on Instagram is just this very balanced approach to life.
Yeah.
And I love that, because I think anyone who follows you is going to be, see you practicing the things that you preach.
Well, I really appreciate that, friend, because I watch you too, and I am inspired by you as well.
Oh.
But I think that's the goal, is like showcasing what we do to let women know that it is possible.
Yeah.
Do we F it up sometimes?
Of course.
Absolutely.
Yeah.
Are there horrible days and weeks that we don't get it in? Yeah.
Yes.
But you keep going.
And you just try to find a way, like you just try to love yourself enough.
Yes.
We are worthy
Yeah.
of the time and space to move our bodies.
And society has told us a lot of the opposite of that for years and years, that we're not worthy. Your worth is in your reproductive years, and after that, you're not. So I'm really trying to squash all of that.
Well, I mean, you are, a great example of just the possibility of this time period. One of the barriers, I think, for a lot of women is figuring out how to build in that time when you've got a lot of other demands, right? And how do you have that conversation with a partner?
Yeah.
And what does that look like? I think for women, I have a direct message. I have not yet answered this woman who reached out. She's like, my husband works all day. She has a young child that was like an oopsie. She's in her late 40s. So she's home with the baby. She has a 14-year-old and a 16-year-old. Her husband works all day. And she just is like struggling to figure out, she feels her mental and physical health declining. She has really bad symptoms.
Yeah.
So she's just like in this place where she's like, when he gets home, like she just is like, she doesn't know how to have the conversation and be like, he's worked all day.
Yeah.
And like she needs to cook dinner and like, just is really struggling.
This is one of the other features of the perimenopause, menopause phase, is the emotional aspect and the mood that comes with that, because it is real, and there's changes in the neurotransmitters that interact with estrogen. This is where we start to see the highest diagnoses in women of anxiety and depression. And it makes sense, because there is an internal shift going on, but we're also in a time in our lives where we're still taking care of families.
Yeah.
Sandwich generation, she has a younger child. Sometimes it's taking care of older parents.
Yeah.
This is where we need to start to form the team around us that's going to help us. So, for example, and not to say that she has to do this, but when I have patients that come to me with those same kind of concerns, is how do I empower now the people around me to help me? Because a lot of times we bear the burden.
Yeah.
And so even having the conversation with the 14 and the 16-year-old, if you can watch the little one for even half an hour, each of you just do half an hour, where then now I can work out.
Yeah.
Right?
Just go in the basement, do push-ups, body squats. And maybe, you know what, you just want to sit there with a book.
Right.
That's okay too.
Even if you want to sit there and pick your nose. Like, I don't care. It's the time alone where we get to pull back and say, I need help. We are not very good at asking for help.
I know, right?
And then the partner question is incorporating that. This is very hard. I have a lot of women who are in the same thing. How do I now engage my partner with what is going on? And this is why men need to be a very important part of this conversation. Is because, again, I do believe that when we think of women's health, and specifically this stage in our lives, patriarchy has a lot to do with the empowerment of who we are, self-worth, and I can't ask for help because I'm supposed to be doing this and this alone. And so that's where you have to, and it's not going to be overnight, but it is this constant conversation of, this is what I'm going through and I need help. How can you be of help to me while I'm still providing help for you? Yeah. Right? So it's the balance of, we are doing this together, but I do need help. Yeah. And then the other side of that is the little ways that you can, we said it earlier with the movement, right? But now it's not only the movement, but the nutrition. Yeah. And finding a doctor, because if you're having symptoms, she needs HRT exposure, right? And I had a patient. This is like one of my most challenging stories, and she had a hysterectomy. So hers was different. Her hormones were taken away through the surgery, and she literally just went like rock bottom within like a week after the surgery. And so it's the same thing of where this is a real occurrence. It is happening. Women need to be seen and heard. And so she needs to have an advocate on the clinician side who's going to say, I need you taken care of, your symptoms resolved, but also for you to feel better here, because it's a mind-body connection. This whole thing is a whole body, whole mind connection. It's small changes. It's never for the big change. I never say, we have a cruise ship and we're just going to turn due south. No, it takes time, right?
It's a big, wide turn.
It's a big, wide turn. And so it's the same thing with our lives, is have patience for ourselves and really like showcase it. We are doing this journey of life and self-love, but the journey is not overnight.
Yeah, it takes time. Yeah, thank you. I think that's really beautiful advice. And just
grace. Give herself grace as well. Yeah.
Asking for help is hard.
I suffer from that. Yeah.
Yeah. And I think it's finding community inside your community too that can be really helpful.
And asking, hey, I have this issue. How did you work through this?
Yeah.
What are some best ways? What do you think I can ask for? And even if the answer or the question rather isn't received the best way, there's a lot of defense that comes with asking for help. Right? And that may need to be refined, retuned, but it still needs to be readdressed.
So, as we think about the future, what study are you dying to see? Like what needs to be done?
Well, there's a lot, but if I, when I think about where we are right now and where I would like us to be, is really looking at this preventative stage of what, kind of where we started this discussion. We know a lot about the menopausal, and from the WHI, we actually had a good amount of information from 60-year-olds and a little bit older, because those are the ages of the women in that study. But what I would love to see is a lot more data in that time frame as we're going through the decline of estrogen, progesterone, and testosterone, in what we can actually impact there and what it will show in 20 plus years. If there is a difference between kind of where we saw most of the studies, which were like you were menopausal or late perimenopause into early menopause. So we have good data on that. I think that we could do a better job at being preventative. And I think that's the age frame at which we could probably get even better outcomes from what we're thinking, because again, estrogen is really that huge facilitator in what happens in our lives later. And so if we wait till it's depleted, what if we kind of push that back a bit and worked with estrogen? I know that there's a lot of data and studies that are going on in ovarian preservation, in the sense of not for fertility, but actually for this ovarian estrogen homeostasis. Because we do know that estrogen homeostasis can then be very profound in when we think of neuromodulation, when we think of mood, brain health, bone health.
100%.
And so now this is the beauty of science coming in. If we're able to prolong that estrogen kind of ability and availability, what would happen?
I love that. Yeah, we send out these women's health surveys. I think now we're in kind of a cadence where it's like every November. So we're collecting lots of data on just different therapies women are on, and we have lots of menstrual cycle data.
Right.
And so one of the things that I'm really excited about is like, understanding, okay, well, what actually is a healthy period? And what is the physiological profile of an individual with a healthy period? And what are they doing? What is their lifestyle? We have all of this, certainly movement. We can auto-classify like 125 activities or something,
so
right?
Now if you're able to kind of compile
we know when they're strength training. We know what kind of cardiovascular work that they're doing. We know if they're drinking and smoking for the most part. We have like a lot of data.
So it's kind of like this lifestyle guide based on a period.
Yeah. So using the healthy period as like, or the period as an anchor of kind of health, right? And then we've got all this other contextual information. But with the idea that, because we'll basically have the data of, we've got women who are in the reproductive years, having a period, transitioning to perimenopause and menopause. I mean, in a decade, we're going to have this entire
a lot of data,
right? Like a huge amount
of
data.
And those changes too. Like what do those changes incur?
Going from one phase to the next and understanding, how do symptoms present in someone who's doing X, Y, and Z as lifestyle, right? No understanding, of course, a lot of it is genetic, but how much actually is it genetic? And I think that's a question that we can potentially ask in our, answer in our data.
Do you have an idea when we think of like HRV, like how that progresses in the 30s into the 40s?
Yeah. I mean, it declines. And when women hit perimenopause, menopause, there's a sharper decline and quite a significant increase in resting heart rate. Yeah.
Which, again, goes to the cardiovascular disease.
Yeah, you got to pay down that risk by like doing the right kind of cardiovascular work.
Right.
And I think that's, doing a lot of the high intensity interval training is probably not, I have Dr. Stacey Sims in my head, just don't get in that zone 3, it just is like counterproductive for women who are in that perimenopause, menopause, where you really want to try to stay as polarized as possible, biasing toward that zone 5. But yeah, I think there's a lot of promise in helping kind of women understand, all right, what do I need to do in the lead up so I can maximize my chance of having, the least, amount of symptoms. And I think combining it with, just this idea of like preserving, like ovarian preservation, like this idea that we can extend that is just
like extending the beauty of our lives longer, but then also enhancing the quality of life when we get older too. I mean, the aging biology is something that I think, one, we age longer, so that biological time frame of aging really has extended itself. But we haven't done so well in saying that just because we live longer, we're living better or healthier. Yeah. And I think that's where if we were to focus more on that, we would start to decrease what we're seeing in outcomes of health predictors, and what people are actually really dying from. It really has a lot to do with things that we're not protecting in that preventative phase.
Yeah, it's such like an important window of time to like
really is.
Capitalize on, and it's like I feel like there's this sense of urgency. You're just trying to like get this information, like so we can set ourselves up for success,
because no one's coming to save us.
No one's going to save us. Yeah. So in your practice, like, do patients come in with a whoop? Like, how do you deal with like the data in your practice? So I know you were really early. You've been a science advisor.
I know.
I just fell in love with you from the moment I saw you.
We met at a tennis match. It was love at first sight. Right?
It was. It truly was. And I was like, I'm going to get this girl in our network.
But look, here we are. So the
I know.
Whoop
but you started using the technology
absolutely.
and like you're applying it. How does it show up in your practice? I'm just curious.
It shows up because usually I'm bringing it up.
Yeah.
And it's a very organic conversation because I'm so big on lifestyle. So the question usually will come from them, well, what are best ways that I can accomplish A, B, C? And I'm like, that's why personalized data is the best way. Because some of the questions that you were even asking me, I don't necessarily have the best answer for you because I don't have your data.
Right.
And so when they understand the behind the scenes of how much better I can do for them if I have data, and then also for themselves, right? So this is something that they have outside, I call it the homework of medicine, is when you leave my office and you're at home or you're at your kids' volleyball practice or on the weekends traveling, you are now in charge of your own data and you get to see when you reach for that certain food, when you don't exercise, when you drink alcohol, when you're not sleeping, what is that doing internally? So it's kind of like to that pictorial of what I was saying earlier of like a lot of people don't have a very good view of what's going on inside, but that's actually a way that they can. Just a quick story is I cannot remember where I was, but it was a gentleman and we were doing some work together. I was traveling and of course he had a whoop on. I was like, oh my gosh, I have a whoop too and blah, blah, blah. And I was like, and he said, oh my gosh, this has been such a game changer for my family because they link it all together. Yeah. And so it actually creates community within their whole family of who's doing what, who worked out today, what was your, it becomes like the scoreboard.
Yep.
And I was like so fascinated that he had incorporated it into a way that the family can be together in health.
Yeah.
Yeah.
I know. I mean, we experienced that same thing. Like my son just like texted in our little group chain that he's like, my restorative sleep, like he's like, I'm like at 5 hours. He's like, I must be like growing, like, so he's got this, idea that he's got this
way ahead of the curve. I'm sure his friends are like, what are you talking about?
It's so funny because there are so many kids in his high school who wear Whoop. Like it's just kind of taken.
He's the trendsetter.
I think he and my daughter are the trendsetters. Yeah, they both wear it religiously, but now you can't go to the the basketball courts without like everyone's got a Whoop on them. Like,
I
this
love
is wild.
That.
Yeah, it's so
that.
cool. It's really neat to see this kind of emphasis on, like they talk about sleep, they talk about recovery. I mean, I just. It's incredible, to see at this young age them, kids starting to learn their body and understand their body in a way.
Well, that's the way we are going to change medicine is if you change the consumers.
Exactly.
Right, and the consumers then now demand, I need to know
higher
this about
bar.
my body.
Yep.
I need this about my health.
Yeah.
My sleep is not doing well. It's only 5 hours of restorative of sleep.
Yeah.
And so then it drives science and clinicians
and puts the pressure on clinicians
to do better. Absolutely.
Yeah.
And so I see that as very promising, especially in women's health.
Agreed. Yeah. I had questions that my daughter asked. So I'm just like, wow, I mean, I think back to, I didn't know.
I was
shit.
like, what is a period?
I know. The depth of understanding. And that's where, I push back. Like I hear you should not be using technology because it takes you further away from your body. But I'm like,
you can learn more about your body.
Absolutely. Like there's not like people, especially people who have not been, athletic in their life and just haven't, I would even say some athletes don't actually have the somatic awareness because they've learned to disassociate from their body.
Yeah, because they're pushing themselves
the
to another limit. Right.
Yeah.
Right.
So, I just see technology as this amazing resource to actually bring us closer to our body.
It allows you to use two modalities. If someone's truly doing it in a way that they can use both ways of self-awareness and what is my body feeling, but also what is my body telling me that I wasn't aware of, but it's right here.
Yeah, exactly.
It showed me right here.
Yeah. When it confers and when it disagrees, that's a source of insight every time. You do a lot of different types of movement, which is cool, like Tai Chi and like you play tennis and you do a lot of different things. Maybe just talk broadly about just because you're so playful, like you have this wonderful, like joyful, playful way about you. And I think, we're talking really strategically, but at the end of the day, it's about play, right?
It's all about play. And realizing that as humans, we actually need play to grow, to thrive. And then the best way of learning is actually through play. I think I learned that through my kids. I mean, we were talking earlier about kids and boys especially. I have two boys, but they're just so, like play is so part of their lives. But that really is allowing them to learn how to respond, interact, and grow. And it's a very essential part of brain growth, too. Right. And so even though I may not remember that all the time, because I'm like, oh, my gosh, get off that couch. Or, you're falling over. That is a really integral part that I think sometimes we lose that in adulthood. Yeah. And I think that we have to come back to that. I'm learning that myself is like coming back to play, like not everything needs to be so serious, especially as a scientist and a physician. I'm just like, oh, my God, everything is double whammy so right there. Serious, right? And so learning that especially as I progress through perimenopause, is taking a step, taking a breath, taking a moment to, it's okay to play.
Yeah, I love that. What's one message you would want every woman in her 30s, 40s, and 50s to hear about her health and her future?
Yeah. Writing Generation M was probably, you go into writing the book thinking, I'm going to give all this information, scientific, medical knowledge. And it is very cathartic writing the book. The process of writing the book, this, is that it requires an extra version of yourself outside of time. There's a lot of time that goes to it, but it really pulls out things about you that you didn't know. As you're writing it, you're having experiences that work its way into the book. When I look at Generation M and when I completed it, I think it really hit home for me when I was doing the audio version. I had to read it. And that's really where it sunk with me, that all these pages I had written was really this love letter to women that I'd seen in my practice, to myself going through it. And I see this transition of menopause is so much more than clinical, even though it's a clinical diagnosis. It's this beautiful way in where we get to say, how do I want to restructure the rest of my life? Because 40% of our lives are lived in the postmenopausal phase. And I really think a woman's journey has been so plagued with a lot of expectations, obstacles, stigma. And we get to redefine that in this next chapter. And that's why I think that we have to do a really careful job at how we portray menopause, how we talk about hormone replacement therapy, and how we also talk about the beauty of integrating all of it, because all of us get to live this beautiful life. It's a gift. And so I want women to approach menopause as something that they get to take part in and have advocacy and awareness for themselves and self-love.
So beautiful. Your book is amazing.
Thank you.
I think it's important to call out that this is not just a book for women. If you are a man who has women in your life, this is a book for you too. I think that we have to support each other, is to learn about these different phases of life that are really transformational. And
they are.
And I think what you've done is you've done an absolute rebrand of menopause. So you have achieved your mission, and in the process have just inspired hundreds of thousands of women. Good Morning America to all the platforms that you have been able to grace, and so just thank you for the work that you have done and are doing to empower women at every phase of life, but particularly during, what could be, and is, a difficult transition. But thank you.
Thank you. I just love being here with you as a friend, as a colleague, but also as women who are going through that stage in our lives. Like it's real personal and upfront for us right now. So I really appreciate the time with you and then also your words.
Yeah. Thanks, Jessica.